Hello, my name is Dr. Mustafa, and today we are going to learn about another important topic, which is ABGs. So, ABGs are basically arterial blood gases that we will encounter in our daily ward rounds, in emergencies, in ICU as well. So, it is important for us to know about them. But before looking into that, we need to make sure we understand what is the patient's clinical presentation and his history. Other than that, we need to look at any labs that is available and also the record of the patient to see like what exactly is going on, and from that it can lead us to our diagnosis as well. So while reading an ABG, we will be looking at many components. So we look at pH, partial pressure of carbon dioxide, bicarbonates level, partial pressure of oxygen in relation to FiO2. Then we have few important things like bicarbonate actual and bicarbonate standard, and then we have anion gaps as well. So so lungs and kidneys will help in regulating the blood's pH. So we can say that the carbon dioxide is acidic and it will decrease the pH, and the bicarbonates are basic and they will increase the pH, and by that it means it will make the blood more alkaline. So the bicarbonates are basically removed or absorbed by the kidneys, and the carbon dioxide is removed or controlled by the lungs. So these both organs will work together to compensate any change in the body if it is within a range that they can adjust. So that's how they will basically help each other out. Now let's talk about each component one by one. I know it's quite a lot, but if we do it in a stepwise manner, it's quite easier. So let's do the first thing, which is we will look at the pH. So the normal pH of the blood is in the range of 7.35 to 7.45. That's normal. If it is less than that, if there is any number less than that, then definitely it's acidic, and we can say it's acidosis. If it is more than 7.45, we can say it is alkalosis. So it's that simple. And once we know it is acidosis or alkalosis, we will look at the further readings to see like what kind of problem it is. Is it respiratory or is it metabolic? So for that, let's just look at the partial pressure of carbon dioxide, and in that we have a normal range. And as we have discussed, that the carbon dioxide is basically acidic. So if there is more acidic, it means there is more carbon dioxide. So the lungs will basically regulate the breathing rate to wash out carbon dioxide or retain more carbon dioxide in order to maintain the pH as per the body's need. So if we look at these numbers that we have, if it is more than 45, it means there is more carbon dioxide. So there is more acid in the body, let's say. So that would be acidosis. And as it is linked to the lungs, so of course it is respiratory in origin. So we can say it is respiratory acidosis. Similarly, if it is less, as the carbon dioxide is washed out of the body and there is less remained, it means it is less acidic, which means it is alkaline in nature. So we can say it is respiratory alkalosis. After looking at the pH and the carbon dioxide level, we will look at the third thing, which is bicarbonate level. So these will basically tell us if it is metabolic in origin or not. So the normal value is from the 22 to 26, and it could be like the high range could be up to 28 as well. So as we know, bicarbonates are basically basic and they are absorbed or excreted by the kidney as per the body's need. So if this basic thing is less in the body, it means it is more acidotic. So that would be metabolic acidosis. But if this basic component is more, then it will be alkalosis. And because it is a metabolic component, so we will call it metabolic alkalosis. So that was the straightforward thing. So now we know about the pH and the carbon dioxide and the bicarbonates, and we can see if it is acidotic or alkalotic. So what really happens that when there is a disturbance in the body, the lungs and the kidneys will work out to compensate that. For example, if the respiratory rate was high, that was leading to carbon dioxide to be washed out of the body, which means the less carbon dioxide is remained back, and it will lead to respiratory alkalosis. And in order to compensate that, the kidneys will basically excrete the bicarbonates, and they will try to lower down the pH. So that's how, when one segment is more, the other organ will basically work in order to maintain a normal level of pH in our blood. So that will basically help the enzymes and the proteins to function normally. So let's look at some of the examples to see if we understand, like, if it is acidosis or alkalosis. So suppose we have an ABG and we have this example. So pH is 7.25, carbon dioxide is 60, bicarbonate is 25. Let's have another example. pH is 7.5, carbon dioxide 40, and bicarbonates 29 milliequivalent. Just to see, like, if it is higher or lower, let's write down the normal range. So 7.35 to 7.45, and then 35 to 45, and then we have carbonates 22 to 26. So in the first one, the pH is definitely low, which means it is acidosis. Carbon dioxide is high, which means it is respiratory, and the bicarbonates is normal, which shows that there is no link to that. So it appears to be respiratory acidosis. Now let's look at the other example we have. So the pH is 7.5, definitely high. That means alkalosis. Carbon dioxide is normal, and bicarbonates are high. So it appears to be metabolic alkalosis. So, okay, it was straightforward. So let's have another example. Let's say the pH is 7.30. We have carbon dioxide 68, and the bicarbonates are 30. So let's look at this. So the pH is definitely low, that is acidosis. Carbon dioxide is high, it means it should be respiratory acidosis. But the bicarbonates are high as well. So in this situation, we need to see that the pH is low, so definitely it is acidosis, and the rise in carbon dioxide explains the acidosis, but the bicarbonates does not. So this is basically the kidneys trying to compensate it. So it is partially compensated respiratory acidosis, in which the pH is not entirely normal, but the bicarbonate levels are a bit higher to basically bring it back to the normal. So that's an example for compensation by the kidneys in case of respiratory acidosis. So by these three basic things, the pH, partial pressure of carbon dioxide, and the bicarbonates level, you can tell if it is a respiratory, metabolic, or if it is compensated or not compensated. So let's move on to the next segment, which will tell us about the oxygenation. So that is the partial pressure of oxygen, and we always check the partial pressure in relation to the FiO2, which is the fraction of inhaled oxygen. So let's just look at this diagram. We have a bucket and we have an old school tap. So let's say we turn on the tap and the water is coming down and it is going in the bucket. So the water that we are supplying is basically the FiO2, and the water that is contained in the bucket is basically partial pressure of oxygen. So we can say that FiO2 is basically the supply of oxygen, and the partial pressure of oxygen is basically the dissolved oxygen that will be ultimately like used in the body or stored in the body, or bind in with the hemoglobin to be used. So the FiO2 at the room air is 21%, and we can increase the supply by using different kind of masks, cannulas, and here are some of the examples. So it is basically the supply, and let's look at the partial pressure of oxygen now. So the normal range for partial pressure of oxygen in the blood is almost 80 to 100 millimeter mercury. And just to understand, like, why it is important to correlate these two things, let's say we have a patient and his dissolved oxygen is 93 at FiO2 21%, which means at room air he's maintaining oxygen level of 93, which is normal. And let's say we have another patient who is maintaining the same saturation at FiO2 90%. We say we are using a non-rebreathable mask. So these two things are indicate that these two patients are not the same. So we basically use the ratio of partial pressure and the fraction of inspired oxygen to comment on the respiratory compromise, if it is there or not. So the normal range is more than 400, but if it is less than that, we have different severity scale to tell us about the condition. So the we have in hypooxygenation we have respiratory failure of two types, type 1 and type 2. In type 1, it's mainly the problem with the less oxygen, while in type 2, it is kind of a mixed failure in which there is low oxygen and high carbon dioxide levels. It means the patient is retaining carbon dioxide. So if we look at the example, the type 1 can be seen in case of pneumonia, in pulmonary embolism, and in ARDS as well. And in the type 2, patient is basically retaining carbon dioxide. And it could be seen in COPD, in obstructive sleep apnea. We can see it in neuromuscular disorder, and as well as the opioid overdose. So these were the basic common things that we usually interpret while reading an ABG. But other than that, there are few more things that will help us reaching our diagnosis if we have some ambiguity. So you must have seen that there are bicarbonates actual and the bicarbonate standard values given mostly at the bottom of the ABGs. So the bicarbonate actual is basically the actual bicarbonates level that is present in the blood at that time, and it does contain the respiratory segment, which means basically that the bicarbonate's actual level will be affected by the carbon dioxide. So the next thing is the bicarbonate standard, which is basically bicarbonates after correcting carbon dioxide to a normal value. So we can say that it shows a pure metabolic error. So the standard here does not mean it's a standard normal value. It means the carbon dioxide is standardized. So we can say that if the bicarbonate standard value is normal, then there is no true metabolic problem going on in the background. But if the bicarbonate standard value is abnormal, then it will definitely tell us about that there is a metabolic disorder going on. So it can be useful when we don't know the metabolic component of the problem is present or not. So it can be a good indicator in that case. Now let's talk about our final thing, which is the anion gap. So this is also important and it's quite easy to understand. So an anion gap basically tell us about the cause of metabolic acidosis. So once we know that the pH is on the lower side and the bicarbonates are also on the lower side, so that will be indicating metabolic acidosis. So we can look and calculate the anion gap to see what could be the reason behind it. So the normal value is 8 to 12 millimole per liter. So we have basically two formulas for anion gaps, but you can use any of that, it doesn't matter. In the current formula, they have basically omitted the potassium, but it's okay if you use it. So you can use any of these formulas as written here. So based on this, we can calculate the anion gap, which is basically the difference between the positive and the negative ions. So it could be high or it could be normal. So there are a few conditions in which it could be high. For example, in sepsis, in diabetic ketoacidosis, in case of shock as well. And this anion gap can be normal in case of diarrhea. It could be normal in early phase of renal failure, and also in the cases when we have given a very excess amount of normal saline, then it can lead to basically a rise in chloride level, and that will depict a picture of a normal anion gap, but we can have a normal value in that as well. So this was basically all about the ABGs. So I hope it was helpful. Thank you for watching. If you have any questions, just let me know.